Good evening, respected professor and my dear students. I welcome you all to another session of RISA DNB online academic activities. Today's session will be on applied anatomy, physiology, and relevant pharmacology of central nervous system and anesthesia by Professor Nagaswamy sir in an interactive question and answer session, which is very welcome by all our students and on our YouTube channel viewers also. Over to Professor. Thank you, sir.
Thank you. Good evening, everybody, and advanced Diwali wishes. All of you must be in the mood to celebrate the Gala event. Just as we discussed the combined forms of anatomy, physiology, applied pharmacology, wherever required, biochemistry of cardiovascular system and respiratory system. In this class or one or two class may be required extra to discuss about the central nervous system and nervous system as it is. I don't say central nervous because nervous system consists of both the central nervous system and peripheral nervous system. So there are a lot of anatomy and physiology questions repeatedly asked in your DNB theory paper, as well as relevant clinical case scenarios where Viva also will be useful by learning all these points. So, and again, like other classes we had, it is not a didactic lecture. It is going to be interactive with question and answers type. So I'll just share my screen for the presentation. Is it visible?
Yes, sir. Visible, sir.
Okay. So instead of saying just anatomy, physiology, I have coined again this as a basics of nervous system for anesthetists. In this, we'll have to know the first anatomy. We'll have to know about the structure of neuron, classification of nerve fibers, anatomy of cerebral circulation, blood supply of spinal cord, and the importance of epidural space. So these are the areas which are repeatedly asked in the examination. So I thought we will discuss and learn about them. With regard to physiology, we must know about the synaptic transmission. What are all the neurotransmitters which are involved in that? We must know about blood-brain barrier and blood CSF barrier, CSF formulation, circulation, reabsorption, and its functions, and how it contributes to intracranial pressure. Pain pathway is another important physiology topic, which is also asked in the theory examination. And those of you who in future want to take up pain as a specialty and practice pain medicine, this has to be the basic foundation. And this other topic of consciousness and sleep, earlier DNB questions repeatedly asked, compare the normal sleep with anesthesia or general anesthesia, and how consciousness is preserved, and what are the evoked potentials and how they are useful, and how do you interpret an EEG, and structure and functions of ANS. This is another topic which is repeatedly asked, and the structural functions, nature, and the pathology of autonomic neuropathy is another important question. How do you assess the autonomic nervous system integrity, especially in diabetic patients, is also another important topic that is repeatedly asked. And lastly, the drugs which act on the nervous system, right from your general anesthetic agents, local anesthetic agents, analgesics, both opioid, non-opioid, then anticonvulsants, their uses, anti-Parkinson's drugs, their interactions, antidepressants and mood elevator drugs which are used, and then their interactions, antiemetic drugs, all these things come under the pharmacology of drugs which act on the nervous system. So this will be the basic overview of the topics that we are going to discuss. And First, we'll start with, can anyone describe the structure and properties of a neuron, which is the basic fundamental structure in the nervous system? How do you describe the structure and properties of a neuron, which all of you would have read in your anatomy class? What are the parts of a neuron? When I say interactive, some of you should answer. You can unmute and then answer the question. Then we will go ahead. Do you know every neuron has a cell body or a stroma from which you have projections? What do you call those projections as?
It has a body,
Cell body,
axon or soma, dendrites, and the nerve terminals.
So that is the answer. So it is as easy as that. So what are the functions of the dendrite and what are the functions of axon and what is the function of the cell body?
cell body, this contains nucleus and cytoplasm, which acts as the network for signal transmission.
Okay. What about dendrites? What do they do and what is axon?
So dendrites and the nerve terminal, which has connection with the adjacent neurons, and they'll conduct action potential from one neuron to the other neurons.
Okay. What about axon then?
Yeah, helps in conduction of action potential from.
So one should receive and one should transmit. There is an input, there is an output. Okay. So that is how the dendrites and axons are. Both are involved in transmitting the action potential. But dendrite is one which acts as an input signal and axon acts as an output signal. Okay. So this is the simple picture given in a very important textbook of anesthesia, physiology for anesthetists. And I have copied this from that book so that it will be easy for you to draw in the exam if this question is asked. So you can see this is the cell body which is called as soma. And as you rightly said, there is only a nucleus here. But where are the mitochondria? Any cell should have not only the nucleus but also other organelles like mitochondria, the reticular formation, that is endoplasmic reticulum, Golgi bodies. All these things are the basic organelles in any nerve cell. But this nerve cell or the neuron has predominantly got a nucleus. So where does the energy production take place? From the mitochondria utilizing oxygen, glucose by aerobic metabolism. Which part of
the axons?
The mitochondria are present only in the axons, okay, not in the cell body. Unlike the other cells, which have the mitochondria inside the cytoplasm, apart from the nucleus, the mitochondria is mainly present in the axons, and the axon is only a single one, whereas dendrites are multiple. Okay, so the dendrites, they come into contact with other axons from other cells. So there are multiple connections, and they have dendritic spine, and their main function is to cause an input. So if you see a typical, this is called a multipolar neuron, is comprised of a soma or cell body, axon and dendrites. The axon is thought to be the part of transmitting let's close this. Transmitting efferent signals, while the dendrites are receiving afferent signals from their surroundings. So dendrites cause an input and axon causes the output from the soma. And the soma contains nucleus, a rough endoplasmic reticulum containing basophilic granules which synthesize proteins necessary for neuronal function. And the axon that leaves the cell body contains mitochondria, microtubules, neurofilaments, and smooth endoplasmic reticulum. And its junction with the body is called the axon hillock. You will shortly know why I have given importance to this axon hillock. When a neuron is activated, an electrical impulse called action potential is generated at the axon hillock only, this portion, and conducted along the axon. Okay? And the axons typically end in an axon terminal at which neurotransmitters, neuromodulators, or neurohormones are released in the conversion of electrical signal to chemical signal, which can cross the synapse or neuromuscular junction. Okay, so even between two nerves, if they are contacting, that is one axon going and putting your axon of spinous ligament coming in contact with synapse, the primary conduction is by electrical discharge, that is sodium coming in and potassium going out. In that way, depolarization occurring, which is called the electrical conduction. And what are these gaps known as? Node of Ranvier. What is the function of this node of Ranvier?
So, saltatory conduction.
Excellent. So for a faster transmission, instead of traveling all along this length of this axon, when the action potential comes here, it will jump to the next constriction like this, and then jump here. So there will be a faster transmission, and that is possible because of the presence of node of Ranvier, and they are myelinated. This myelin sheath is covering. So all myelinated fibers conduct impulses faster, whereas unmyelinated nerves have a slower conduction. So the transmission of action potential along the nerve fiber by the axon is electrical in the beginning, and at the junction where it goes and joins either another nerve or at a muscle, then it becomes by a transmitter or a hormone substance, so it becomes chemical at that nature. So it is called electrochemical conduction or electrochemical transmission. Okay, so that is the basic structure and properties of a neuron. And axonal properties are carried out by proteins such as kinesin and dynein. These are the two proteins which help in this conduction also. Now, what are the types of ion channels which are present in the nervous system?
Voltage gated sodium channel and
Sodium
potassium
channel.
channel.
Okay.
Potassium voltage gated potassium channels.
So they can be called as ion channels. Okay. Together, whether it is for sodium or whether it is potassium, whether it is chloride, whatever ion is conducted, they can be broadly called as ion channels. Okay, that is one type of conduction. Agreed. Or any other type of channels? And these ion channels, are there any difference in their functional status by which you can classify them? The ion channels, they can allow the transition of or crossover of either sodium, potassium, or chloride from extracellular space to the intracellular space. That is, it is like a pathway or a corridor. Okay. So what are the, how do they function? Functionally, how they are classified. So if you see this picture, this is the easiest picture again taken from the same physiology book, where you can easily remember. The first type of channel is called an open channel, which remain open all the time, but they don't actively conduct the passage of sodium or potassium. So these are the basic ones which allows small quantities of sodium or potassium to go inside or outside, and they are open at all the time, and they are called the open channels, which help in maintaining the membrane potential at resting state. Okay, see these ion channels are essential for maintaining the electronegativity inside the cell and electropositivity outside the cell. So that is how nature has made it the open channel. The second type of ion channel is called the gated channel, voltage gated channel, and that channel is, ligand gated channel, and this will activate or become active only when a ligand comes and occupies the space. Like, for example, at your neuromuscular junction, when acetylcholine is released from the neuronal presynaptic nerve ending, then it traverses the synaptic cleft and comes and occupies the acetylcholine receptor, then only the channel will open. So this is called a ligand gated channel activated by a specific ligand. It may be acetylcholine, it may be noradrenaline, it may be serotonin, it may be epinephrine, or it may be other neurotransmitters. The third is what is called the voltage gated. Whenever it is closed at resting stage, opens when the threshold potential is reached. That is when the voltage becomes more positive inside or depolarization starts, then it opens and then allows all the ions to pass through. So it can be called as non-gated ion channel found throughout neurons, which are essential for maintaining the resting membrane potential. The second type of ion channel is ligand-gated ion channel, which are present in dendrites, dendritic spines, and cell bodies. And the third is voltage-gated ion channel, found mainly in the axons and axon terminals. So their location is very, very important. And next important point we all must know is how nerve fibers are classified, because their size and their myelination, all these things only decide how they are going to function, whether they can transmit the impulses faster or they take time and they are slow conductors. All that can be decided only when we know the what type of nerve fiber it is. So how do you classify the nerve fibers?
So based on the
So
diameter
depending
and
on the
conductance, A alpha.
One at a time. Yes.
Depending on the diameter and the conductance, it is A alpha, A beta, A gamma, A delta, B and C fibers.
So it is broadly classified as ABC, and under A there are 4 subtypes: alpha, beta, gamma, and delta. Correct. Any other classification? This is the common classification we all read and know about.
sensory and motor types.
No, whether it is motor or sensory, it decides on the size and all these things which come under the ABC classification. Okay, so you can classify them as based on the axon diameter as motor and sensory, and under the motor it comes as A alpha, beta, gamma, delta, and B. Okay, and C fibers mainly transmit the pain and the temperature sensation, whereas the sensory nerves under the sensory transmission, they are classified into Roman letters 1, 2, 3, and 4. Okay, again they are based on the diameter and their velocity or the speed with which they can conduction. Okay, so this classification of 1, 2, 3, 4 Roman numbers is not commonly used. It is mainly for the purpose of knowing the conduction velocity and what are all the types. But in practice, we use more of this classification, where it is classified into first broadly into A, B, C, and A is divided into 4 subcategories. And A alpha fibers are the thickest fibers. They are the maximum size 10 to 20 micron, and their conduction velocity is 60 to 120, and they mostly carry motor fibers which stimulate and contract the muscles. So they are called motor fibers. All the rest of them, mostly they are all conducting the various modalities of sensory sensation. That is touch, pressure, proprioception, pain, temperature, and some of them are preganglionic, and the C fibers are mostly postganglionic as well as they carry pain and temperature. Okay, so A alpha is the biggest, A beta comes next, gamma, delta. So as the classification goes down, the size, the diameter also goes down, and the speed of conduction also goes down. The smaller the fiber, lesser the speed. Larger the fiber, larger the speed. Why this knowledge is important for us as anesthesiologists? When you give a block, when you try to block the sensation of a nerve fiber, when you apply local anesthetic in the vicinity of the nerve fiber, the nerve fiber may be purely motor or a purely sensory fiber or a mixed nerve, where it has both motor component as well as sensory component. So this knowledge, by knowing this, what do you achieve when you think of giving a local anesthetic block to the patient?
We can decide the concentration and the volume.
Excellent, very good. And what about the speed of onset of block? Which nerve will be blocked first? Which nerve will be blocked last?
Sensory, mainly the temperature will be blocked first, sir. Smallest
Smaller the size of the nerve fiber, faster the onset of blockade. Larger the size of the nerve fiber, later or delay in the onset of blockade. Okay, so whenever you have a very small nerve fiber, that nerve fiber will be blocked very fast. Whereas when you have a very thick nerve fiber like sciatic nerve, when you want to give a sciatic nerve block or a femoral nerve block, you will have to use a larger concentration, as well as the onset of motor block will be the last one. You will have sensory block early, and you will have the autonomic block also much more earlier than sensory block. That is why what are all the clinical conditions where you can use this differentiation in the onset of block as a diagnostic modality? Any clinical situation where this difference in the onset of timing of block and their effects made use of, not as a therapeutic modality for conducting surgery, but as a therapeutic modality, I mean, as a diagnostic modality for deciding a treatment in future. Supposing a patient's limb is not receiving adequate blood supply, okay, like a condition like what is called thromboangiitis obliterans. Have you heard of a condition called TAO, thromboangiitis obliterans?
Yes, sir. Peripheral arterial.
Peripheral arterial disease. In that situation, what will be the temperature of the distal portion of the limb which is affected by this disease? Will it be cooler than the normal blood supply limb, or it will be same temperature or higher temperature? When a blood flow to a part of the body is decreased, will that part will become cold, or will it become warm, or it will remain normal in temperature?
Become cold, sir.
There is a lesser degree of temperature because blood is not flowing, warmth is not supplied to that area. Okay, so in that particular condition, TAO, thromboangiitis obliterans, how can you improve the blood supply? It is supposed to be a condition where there is an intense spasm produced by the autonomic nervous system in that limb. So how can you relieve that spasm? What should you do to relieve it? Which part of the autonomic nervous system will make the vessels constrict, and which part will allow them to dilate? Stimulation of which component of autonomic nervous system causes a widespread vasoconstriction, and blocking that will cause vasodilatation. Which component of ANS, autonomic nervous system? Is it sympathetic or parasympathetic? Yeah, you should not take this much time to answer. What is the effect of sympathetic nervous system on the vessels? Does it cause vasoconstriction or vasodilatation?
Vasoconstriction, sir.
So if you block the sympathetic, what will happen? Vessels will
Vasodilate.
dilate. So when the vessels dilate, what will happen to the blood flow? Increase or decrease?
Decreases, sir.
The vessel dilates, more flow can occur or less flow can occur. Imagine a constricted vessel and a dilated vessel. How do you say it will decrease? Vessel is now dilated. Okay, I think you have never heard of this particular clinical scenario. Okay, so it actually dilates and improves the temperature. So they use this as a modality to diagnose whether a permanent sympathectomy, lumbar sympathectomy, will help in the improvement of the blood flow before thinking of amputation in a ischemic limb because of the severe intense vasospasm produced by sympathetic overactivity. You give a very, very low concentration of local anesthetic into the lumbar plexus, and the C fibers, which are the sympathetic fibers, they are blocked. So once the chemical sympathectomy, this is called chemical sympathectomy. So you block the sympathetic outflow from the lumbar plexus and record the temperature in the affected limb before and after the procedure. If there is an increase of 1 degree centigrade in the temperature of the affected limb, then that person will benefit enormously by doing a permanent sympathectomy. So this is one of the diagnostic procedures that are done. And they also used to call something as a differential spinal anesthesia. Have you ever heard of that? What is differential spinal anesthesia? Which happens whenever you administer a subarachnoid block. Examiners are very fond of asking this question. What is differential spinal block? When you administer spinal anesthesia for a surgery, let us say it is for an orthopedic surgery. Many of you are all
so the level of motor, sensory, and the autonomic will vary.
Will vary.
Yes,
Why it varies? Which will be lower? Which will be higher? Which will be in the middle? Supposing
autonomic will be higher, sir. Sensory in the middle and the motor is the lower, sir.
Excellent. Okay. Why that is happening? That is because of the size of that. Okay. So when you administer, say, 0.5% of bupivacaine heavy in the spinal subarachnoid space, what happens? This drug mixes with the CSF, and CSF is in constant circulation and it travels upward. Okay. So 0.5%, if you inject at say L3, L4 space, when it goes to L2, L3, one space higher, as the drug travels, it gets diluted with the CSF. It becomes 0.4%, 0.3%, 0.2%. As it travels higher and higher, more drug mixes with CSF and the percentage of the drug starts dropping. So after a particular time, particular level, the drug becomes so weak that it cannot block any more nerve fibers, even if it is present in a very trace quantity. So the smallest fiber will be blocked up to a very high level. Then the next bigger fiber, sensory, will be blocked. Then motor will be blocked at a lower level. So these three different. So two segments below the sensory level, because we can examine only sensory by either pinprick or by cold application. Okay. So whenever you have say T10 level for a block for TURP, you aim and give a drug in a volume adjusted for aiming to block only up to T10 sensory. Then the motor block will be at T12. and sensory block will be at T8. Okay, so that is how this differentiation will happen because of the difference in the size of the fibers. And this, what is fixation time of spinal anesthesia? Why, when after administering a spinal, you tell the theatre boy or the surgeon not to elevate the limb too much, and you ask him to wait for say 3 to 5 minutes? Why is that? What will happen if, supposing for an orthopedic surgery, both bones fracture lower left side limb, you give the spinal and immediately the theatre boy lifts the leg for application of a tourniquet? What can happen?
The level may go higher, sir.
The level may go higher up. Very good. So if you want the level to be at a particular disposition, you have to keep it. So what is called the fixation time of spinal? If you know the answer that the level will go up, you should be able to answer this question. What is called the fixation time of spinal? That 3 to 5 minutes you wait and then lift. Will the level go up?
No, sir.
No. Why it is not able to increase the level if you do it in a little delayed way? Because the local anesthetic gets so diluted that even if you lift the limb, it will not be able to block any nerve fibers. On the contrary, if you lift it immediately after administration of spinal, the drug will travel faster. So it is not that much diluted and the level can increase. Okay. So when you wait for a particular time, then the drug is evenly diluted and it cannot block any nerve fibers, even the autonomic fibers. So that time required to dilute the drug so much where it cannot block any more nerve fibers is called the fixation time of spinal. So these 2 points you have to remember based on the size of the nerve and their conducting capacity in the spinal anesthesia subarachnoid block. These 2 common questions. One is what is called the differential spinal, which is nothing but the difference in the level between sensory, motor and autonomic block. And fixation time of spinal is the time required for the drug to get diluted so that it cannot travel anymore or block any more fibers. Okay, that is what is called the fixation time for spinal. Now the next question is, what is a synapse?
It is the space between the
Is it a space
between the pre-synapse and the post-synapse.
It happened. Somebody asked for annotation and I'm not able to close this. What happened? To stop this Kamachi, somebody asked for annotation and I just said approve. Soundarya or somebody asked for annotation. I want to close this.
You can close this and come back, sir. Or yeah.
Fine. That's correct, Anuman. I think people should not ask for all these things, annotation in the middle and all that. I'll stop that and then come back again. Okay? It's not